Okay, so now I want to introduce our panelists and moderator for the evolution of value-based care. So number one, we have Laura Breisch, who's the VP of Value Capture at Oscar. And congratulations, Laura, on the recent IPO. It seems like Oscar is just, it's like a big company now. I remember when Mario spoke to our group a few years ago when you had just launched, and it's so exciting to see the progress. We also have Debbie Finnell, who's the CEO of Illumed. Debbie is a managed care veteran who's launched an MA plan in the past that was acquired by Humana. And she launched Illumed about 2.5 years ago to focus on direct contracting entities. So very happy to have her. We also have Michael Meng, who's the CEO of Stellar Health, and which is a very hot startup in New York. And congrats, Michael, on your recent big Series B fundraise. Stellar works with health plans and providers to adopt value-based care. And then we have the legendary Dr. Richard Park, who many of you know was the founder of CityMD, really, truly transformed urgent care as we know it. And so today, Richard is the co-founder and managing partner at Ascend Partners, an investment firm. And he's also the CEO of Render, which is a multi-physician specialty group that serves Asian Americans and other underserved patients in the New York area. Moderating today is David Copance, who is a lawyer with Jones Day, which is a international firm. And David has a huge amount of healthcare experience, which is why we thought he would be a great moderator. I want to thank both Jones Day and Stellar for supporting today's event. And with that, I thank you. I'm going to turn it over to David.
Great, thank you, Bunny, and good afternoon and morning to everyone. And as Bunny just said, we certainly encourage you to submit any questions that you have, and we'll monitor those throughout and work them into our discussion today. This panel is going to discuss, where the healthcare industry is today on value-based payment arrangements, including, what we mean by value-based payments as well. We're going to consider the opportunities, obstacles, and other risks in participating in these types of arrangements. And for a part that I'm particularly interested in hearing from the panelists, we're going to also consider, the various market forces at play that really help define, providers and payers' efforts to establish these arrangements. While we might touch on value-based payment arrangements in the commercial or private insurance context somewhat, our focus today really is on the, quote, original Medicare program and Medicare Advantage, which for Medicare Advantage, as I'm sure many in our audience today knows, is that program offering Medicare health plans through private companies or insurers. So with that, let's jump right into our discussion. And so let me turn to Michael. So Michael, the panel is going to get into more details a bit later, but let's start off with more of a big question. Both Medicare and Medicare Advantage have been largely what we call fee-for-service payers. So when we're talking about value-based payment arrangements, what value do we see these programs trying to achieve that maybe fee-for-service hasn't?
I think the first thing is to jump in is to say that why is it that Medicare, whether it's Medicare Advantage or traditional Medicare, tends to be where value-based care is the most prevalent or prominent? I think it's because there's a lot more spend to control there, right? So that is a reason why there's so much focus here. And then furthermore, certainly CMS and the government and the constructs have pushed greater amounts of emphasis on value-based care in both programs, whether it's through an MSSP or Next-Gen ACO historically, or Medicare Advantage and a lot of the reward systems around quality stars, coding and risk adjustment, and other cost initiatives. That all being said, I think the most interesting thing today, which this panel really knows well, is the advent of DCE or direct contracting entities, right? And in my opinion, I think that's actually CMS saying, I want to bring parity for all members of Medicare, whether you want to go traditional Medicare and be in a DC, belong to a DCE and be managed that way, or a health plan managed Medicare Advantage, either is the same and it should be the same and fine. So I think one really interesting trend that will happen is we'll actually see the two come more and more into parity in terms of the reward systems, how much, the economic rent you can make from it, and the quality that they're trying to direct for those patients or members.
Yeah, right on that point about quality, I mean, as we've seen with the fee-for-service program or payment structure, that can lead to an incentive or focus on kind of the quantity of services being provided rather than the quality. So I mean, when we move to a payment system that is focusing more on the quality of services as opposed to the quantity, how do we see that impact how healthcare is being delivered, as we shift from quantity to quality?
I think others should chime in more on this from this panel, but I do think that this change is a full mindset change, and it's a hard one because imagine if you as a provider have been paid a certain way all your life, right? Not that different from even lawyers on billable hours. And all of a sudden you want to tell them, actually, you're going to be rewarded for managing this entire whole cost. That's a pretty big shift and a pretty big change. But I think it's obviously a critical one for our country that we have to go through. And I think what's really neat is watching all the different entities, players, companies embracing this, right? Certainly lots of companies going public, Deborah's company here, Laura's company, Richard's company. I think it's really interesting to see, how people are embracing it and all the ways that they're trying to go deliver on this exact fact.
And I would just add to that, I think we need to focus on the patients getting the right care at the right time in the right place and reducing unwanted or unnecessary care and shifting the provider and the payers to the more of the quality of the care, keeping the member healthy, giving them the right treatment. It's not only going to benefit the member, but it will also benefit the healthcare system in its entirety in the long run.
I would also like to add that if we don't address how physicians are paid or how they derive their income and how they spend their time, let's face it, it takes more time to manage the patient's outcome versus their episode or their transaction that they're going through at the moment. And that means in this world, reducing the number of patients seen, which directly correlates to their bonus if they're employed or to their overhead revenue if they're own the company. And so being able to be transparent with the providers and compensate them for their time and effort so they can put that effort in to create the good outcome is absolutely at the foundation of making the change.
And so are we, as we see this kind of focus on quality, and I know, with COVID-19, we've seen just an explosion, for example, of telehealth, which very much changes the basically the setting for care being provided, whether, people are still in their homes or some other location other than maybe a traditional bricks and mortar, medical practice or on site at a facility. But as we see the shift from, changing to a more of a focus on quality, I imagine, right, we're probably going to see more non-traditional settings of care and maybe even kind of more collaboration among different types of, professionals and providers that haven't traditionally worked together. I mean, is that your view, kind of where we're heading?
Yeah,
I mean, I'll throw that question to Richard there.
Sure. Well, it's collaboration between one person or one practice and another practice can happen because they're small, they can interact. The challenge, one of the challenges, how do you get large organizations to deal at scale with other large organizations at scale? And so I think people know what needs to be done. Payers know what needs to be done, large insurance companies, large hospital systems. And they're throwing fastballs to the 5% of the doctors that control or have influence over the other 95%, namely the primary care doctors. And the primary care doctors are not equipped to catch the fastballs thrown at them, right? They can't catch it. Why is that? Because especially with government plans where that is still the largest payer of healthcare in the country. It requires coordination. Coordination requires the right incentives, management over infrastructure management with data and dashboards that require workflow. What we have today, if you go into a lot of the offices, and we looked at a lot of the offices, you will go into doctors' offices and you will find Netgear routers that can't talk to each other, and you're going to find Windows 95. Okay, you're going to find literally Windows 95, and you're asking these well-meaning physician groups and doctors to scale and catch your fastball with Windows 95. I'm totally mixing analogies and metaphors here, but I think you guys get my drift. We do need to bulk up fundamentals, and so a lot of groups are looking at raising the ceiling, doing new innovative things, AI, really cool things. Some of us need to function and work on raising the floor, reinforcing the floor, get everyone to at least have Windows 2000. Come on, at least 2000. And then dashboards and workflow. It's really carbon paper, elbow grease workflow at the provider level. So I'll leave it there. So to answer your question about telemedicine, they're great and all, but how do you get physician groups of scale to be able to manage and use it at scale, predictably, reliably, with scale?
Great. And, we're starting to receive some questions as well. And I thought one that might fit in nicely here as we're talking about kind of the move to value or quality. We have one question that asks if, we have any kind of, insight really on the patient perspective of value-based care, where maybe a patient has traditionally been receiving, under the fee-for-service model, specific services, but then we move them under a value-based model, and all of a sudden they're being told those specific services aren't really needed or valuable, to their care. Maybe what their reaction would be, kind of to the change maybe in the types of services they receive under a value-based care model.
I think the thing to call out on this is that CMS has made this explicit. So they are moving CAHPS and HOS, which is the patient experience or survey side of this, to become an ever increasing amount of the weighting, right? So it's actually very explicitly made. And that is actually a challenge because some of the things that where you just have to block and tackle on quality HEDIS measures aren't enough anymore. You still have to do those, but you actually also have to make sure the patient does have this better experience. Now, is there some criticism on how it's done in this patient survey and their own, response to those? Sure. But one really interesting thing that one of our board of advisors, Jonathan Blum, said back to me was, I asked him, why is there so much of this surveying going around? Like, why does this matter so much? And he said back, actually, there's a lot of academic studies on this, that the higher and better that is, the patient experience is super highly correlated with patient outcomes and trajectory and cost. And I thought that was really interesting. And his point was, if providers actually just did provide this better experience, it would actually lead to MLR benefits. And I think I'm fully sold on that now. And I think this is, where some of these maybe primary care delivery 2.0s are going, like Richard's companies, Oak Street, ChenMed, all these folks are pretty focused on this in general. And the one thing I want to caution, is that, as a payer, I would encourage, you can think of it as either I'm only going to contract with those providers who can do this, but then you're going to leave behind all these other providers who need to convert over to that. Or you should think of it as, how can I actually help all these providers get better at this? And that's maybe the one thing I would love to leave as an encouragement.
Yep, and I did want to acknowledge we are receiving some questions. A few of them came in, like one is kind of wondering about kind of getting into direct contracting without any ACO experience. I think we're going to get to that in a little bit later in this panel. So maybe we'll put that off and make sure we kind of address the need, maybe as you think about some of these models, the past experience that you have. We do have another question here for Richard, mentioning kind of about value-based payment building based on like PCP attribution. And the question is, I'd be interested to hear what you feel about moving the value-based payment to specialists rather than PCPs. Does the PCP or specialist have more of an impact to the patient's health?
There's only one group of physicians or providers that have a higher return on investment to do nothing. And that is the non-hospital, sorry for the hospital people, I know there's a lot of hospital people on, but it's the non-hospital based primary care, all right? So they have an influence on the other 95%. So I don't see who else can or should have a part in that. So I do think it's primary care related. I could see there was a question from Ken online. Other people can too, pharmacists, absolutely. There's MA models out there that there's MA models, others out there that have tried to use pharmacists, but I do think everyone has a part. Anyone that can have an ROI to do less can play a part in this.
And I would just add that the PCPs need the visibility and transparency of the data, right? And even though their cost is only about 5 to 7% of the total U.S. healthcare cost, they control about 63% of the total cost. So they have a humongous part in the total U.S. spend of healthcare cost that needs to be addressed, whether you want to call it gatekeeper or whatnot, but they do control a lot of our spend.
I'd like to add as well that the PCPs, you do have to meet them where they're at. Many of the providers, as Richard described, are on Windows 95. If you're going to be in the two-sided risk business, you're going to have resources. You're going to have all kinds of tools, systems, workflows that you need to bring in, provide, and support. The smaller groups don't have the infrastructure or the budget to do that. And if you're not willing to come in and meet them where they're at, they're going to be left out. And then that creates not only physicians, but actual large pockets of people that don't get the same quality care. I think it's our obligation to come in and bring everybody up to the proper level. And I think that the physicians should be financially rewarded for this heavy lifting, for being that medical home for these patients. Many of them don't have equity in the services that they get by default, and that we can make a go of it. Some of the most rewarding, communities I've been in were the poorest and the least amount of services provided in their community, and became some of the most profitable markets that we were in, because you didn't use the stick, you used the carrot. You influenced the patients to a better behavior by working with that primary care. And once you do that, once the patient is connected to their primary care doctor, they're going to be compliant. They're going to rely on you to be their advocate, to remove barriers. And you have sustainability and you have loyalty.
I would also add, this is where I think the health plan partnering with the providers is key. The health plan has resources that the provider does not have, whether that's offering certain benefits for social determinants of health, transportation, Meals on Wheels, or whatever the case may be, and have the resources to do the research of what is being offered in the community, while maybe the provider does not have those resources available to them or don't have the time to do all that extra legwork. So partnering with the health plan, you do take care of the patient in its entirety, and I do believe you'll see a better outcome. If you're taking care of their social needs, more than likely they'll take care of their health in general.
Many times that's the most important driver of the social needs.
Yeah, and I think as I look at some of the questions coming in, I think the themes that you are covering, needing both the provider, the peer involved, having the patient involved. I mean, I think these, right, are all pretty important aspects of kind of achieving the value that everyone is aiming for. I know when I look at some of these, I think we'll get to some of these other topics. We have quite a few questions here. I think we're going to cover some of these in a little bit. Maybe turning to Laura, if we can step back for a moment from value-based payment arrangements and talk about the state of Medicare Advantage. We've seen an increase in the number of startup payers or other new entrants into the Medicare Advantage market. And as you know, in any market, there's a limited number of lives that all the participating plans can cover. So what is your take kind of on this battle, if we could call it that, or kind of competition, between these, longstanding, more traditional payers and a lot of these newer entrants into the market?
Yeah, for sure. So, I mean, in my opinion, I think the new players have the ability to be very innovative, kind of learn from the traditional health plans on what can be done better. In most cases, they're more nimble. They can move quicker. They're not that big, that big ship moving in a bathtub. They can, pivot as needed. It is still hard to to acquire membership when they've been with an organization for a long time. But we also know that there's a lot of new Medicare members enrolling each day. I mean, the baby boom's huge. So there is an opportunity to acquire the new membership, or to expand if they enter in a small group market, individual market, market to the people in the 50s, 60s, so that they can enroll in the Medicare Advantage plan when they age in. I'll be interested to see in about 5 years how the landscape looks, but I do think there is a specific niche that new players, new entrants can take over.
And are we starting to see, in kind of as part of this competition, like, and Michael, I don't know if you were going to jump in to the conversation, but please go ahead.
I was just going to add, I think, like a lot of other consumer products, what I see is that MA plans, whether you're more a traditional player or innovative, you have to meet the consumer where they are, and it's going to probably fragment. Just like a lot of the things we buy today, we all have so much choice, and we decide here are the niches or things I really care about. I think you're going to see a pretty big change of benefit design in local markets for certain demographics or types of consumers that meet them where they are. I actually do know a Asian American focused plan as an example that really drives things that Asian Americans really care about, right? Certain dental things that are pretty unique, or hearing aids that are unique to them, or acupuncture. So I think increasingly that's where things are going to compete. And you see this in other industries. So I don't see why this would be any different.
And so, yeah, I think along those lines, I mean, in terms of kind of tailoring the offerings for kind of the membership as well. I mean, do we see value-based payment being used, population health management, et cetera, being used as maybe tools to kind of attract lives, in the midst of this kind of competition?
Yes.
Debbie, was that you?
Yes,
Yeah.
absolutely. I think with growing the DCE rapidly now, just the value-added benefits that we've been able to offer year one to the Medicare recipient has been what's in it for me, for the patient. Lots of great things in it for the physician and being able to get the proper compensation, but it has an equally valuable meaning to the patient. And when you add sort of the concierge kind of touch that we give to be their healthcare advocate, that no one likes to be on the phone trying to get an appointment to a specialist and they're told it's an emergency and they give an appointment in 90 days. Well, when you're there to remove that barrier for the patient, again, you create loyalty, you create value, you create a bond, which goes beyond the high benefit amounts that a traditional MA plan would offer. I mean, a lot of the value buyers stay in the MA world, but in the new creative alternative payments that are coming out, there's a lot of things that are new to the Medicare fee-for-service world that are being received very well.
So, and then along those lines, Richard, and Laura, I'd love to get your kind of payer perspective as well on this. While we see this kind of competition between the traditional payers and some of the newer entrants into the market, and they're battling for that limited pool of lives. I think there might be other influences, right, in terms of how these individuals will choose what plan will cover them. We have healthcare providers out there, they're treating patients, otherwise helping them, just with many issues even beyond just the treatment. And I imagine they might have some degree of influence on enrollment choices. So Richard, I mean, do you have thoughts in terms of what role are providers kind of playing in terms of enrollment decisions?
I think at the end of the day, a better product wins, always does in the long term. And so I think someone asked questions about Oak Street and ChenMed and the like. Right? And so traditionally what we do today is we take care of the 75-year-old and the 40-year-old in the same office. And they're two completely different, forget about ethnicity and socioeconomics, just age. Two completely different needs. And going back to what Mike says about segmentation, as opposed to groups like Oak Street or ChenMed, completely focused utterly on the elderly and their needs. They like to be picked up and their kids are busy, they're lonely. You know, I don't want to spend 5 minutes. I want to spend 40 minutes, whatever it is. Tailoring it, segmented, perfect care for the perfect person, the perfect way, that will win. So I think it's up to the city MD. We were focused on NPS scores, wait times, and patients per hour. But NPS was wait times is a major driver, and NPS being the lagging indicator. And so if providers create a model where it's great care, whether it's MA or whatever you want to call it, people can flock to it and you can make the economics work. So I am a big believer in hyper-segmentation and matching almost like a bespoke model to the care. And that's why I think ChenMed and Oak Streets and the care, that's in the IORAs of the world. Forgive me, IORA. All of you guys are great and have something to add. And Oscar, sorry.
Yeah, and Laura, I think along those lines, I'd love to hear your thoughts, you know, from the payer perspective too.
So for sure. So I think from a payer perspective, the provider network is extremely important to us, right? You know, how they interact with our members, making sure like Richard alluded to, like the wait times, the care they need, making sure it's responsive. And I think the payer can work with the provider to help alleviate some of the concerns, whether it's helping with scheduling or making sure that we're giving them transparent data, or giving them additional resources because they are so busy in the provider's offices. But, you know, if we make things easier for the provider, I do think that they would, you know, then, I don't want to use the word sell, but, you know, would offer up like, hey, have you heard of this great insurance project or whatnot? Do we pay their claims quickly? Do we make authorizations easy? I do think there is you know, there's a good synergies between the payer and the provider, and how can we make each other's lives easier?
I just want to chime in and add that, you know, to put some figures in, like, think about the average Medicare patient sees their doctor 4 times a year, right? So the broker may talk to you once a year versus 4 times on stuff that's really important to that person. And then actually the people with chronic conditions and sicker are seeing double that. So 8 interactions that are very meaningful to that person versus one where the broker's trying to sell you a product, right? So that's I think the power of the providers in all this. And that's where I couldn't agree with Laura and I think Richard on this one in terms of how important that is. And I think one of the challenges in this whole space is you're trying to bring a product to the consumer that is part payer and part provider. So you need actually both aspects to be really great to win. And so those who form those relationships and really do that are the ones who are going to win.
Yes, sir. And we also, maybe I'll jump in here. You know, Debbie, we had a question directed to you, which as I was scrolling through here, I lost in the feed. But you know, one question was kind of the impact that the pandemic is having on virtual healthcare, and you know, how we see it. You know, maybe let me see here, kind of going forward. You know, whether or not we think maybe some of these changes will kind of contribute towards this effort for value-based care.
Sure. I think that one of the positive things that have come out of the pandemic would be that I have been laser focused on the senior population my entire career. They had been slow to embrace telemedicine, telehealth. Even if you were to have a resource in the office and they were coming to the office to have a telehealth visit, it wasn't well received. And I think COVID forced people to at least try it. And what we see at this point is it's not a replacement for an in-person visit with your PCP, but when you're tightly managing your chronically ill folks, as an interim step, it's a useful tool. We all know that we have a mental health crisis in this country, and the lack of resources, I think, is a main driver for inappropriate emergency room use. And now that they're accepting some mental health resources through telehealth, it's been a big change to the positive for the patient. And I would say also for the provider. We have to be very careful that patients don't silo themselves and resist coming in for visits because it's not a replacement. But I certainly think it has many applications that are going to improve the care that folks get in the home. And it's going to help us span resources, especially in rural areas where perhaps you can't get a rotating specialist through, to be able to use that as a resource in the meantime. So I view the role of telehealth is here to stay. I also think that more aggressive care in the home is going to explode over the next 10 years. Again, meeting patients where they're at. We're not just going to chuck somebody off to non-compliant. We're going to come and find you, and we're going to take good care of you wherever you're at. And I think that that's going to be the two big things coming out of the pandemic.
So then, like along those lines, kind of transitioning to our next topic, which I think is about kind of where we're heading. What is the future? I mean, we've already started talking about the direct contracting model somewhat. The Medicare program, I mean, for years now has been just turning out model after model, demonstration projects, in different initiatives. In some cases, we're on the second, third, or even beyond that iteration of those models. For example, we've gone from BPCI initiative to BPCI advanced. The Medicare shared savings program has just moved to new kind of risk pathways. We could go on and on with all the changes to these models, some that have been left behind. But I guess the question here would be, what is your take on these models and what they really mean for the future of Medicare's kind of value-based, payment efforts?
Well, I think they're necessary. I mean, the insolvency of Medicare and the impending doom there speaks to the fee-for-service program. I mean, Medicare Advantage has been really the only program to significantly save the government money, and that's as limited to 5% as the patients adopt MA. I don't think that any of the alternative payment models really produce savings. I think the most successful was the MSSP with the path to risk. I think track 2 it is, and that, when they factor in the cost of administering the program, because there's so many, saves the government less than 1%. So I think they hit the nail on the head with two-sided risk, the global risk and the DCE. I think it's truly going to be a game changer for the savings for Medicare. And I think to your earlier point, it's going to be the fee-for-service Medicare version of MA. And that's where the time, effort, and energy should be spent. Physicians enjoy transactional medicine. They make a good living at it. They understand it. They can control it. The more patients you see, the more money you make. And that has been to the detriment of the Medicare program. I think, going back to what I said before, having the doctors work smarter, have them participate. And now that money is flowing down to the provider, which was the intention of Medicare, not to make a lot of money, but to share that money with the providers that are impacting care, and to provide extra benefits and make sure that the patients don't have health equity with the more larger metropolitan areas where resources are greater. I think all those things are pinged with the DCE. And I think the reason they shut the window is that, unlike the ACO project, they don't want so many cohorts that it becomes administratively burdensome. Let's face it, we struggled this past year with the rules being understood and implemented. And I think that they've done absolutely the right thing by limiting the number of DCEs coming into the program. So let us prove the concept. And I think that will go a long way for, if not saving the Medicare program, but allowing us more time to fix it.
I think when I just to jump in with on Deborah's point, when I look at the DCE model and I compare it to some of the Florida MSO for Medicare Advantage, they look really similar. And I don't think that's an accident, right? And if you look at Medicare Advantage in those Florida MSOs, I think a lot of them have run in MLRs in the 60s and 70s. So they can be successful. I think that's where they said, well, okay, maybe we need to give this global cap idea over to the providers who can take it up. Not all will, but those who can, it will work. And so I think it's really interesting how similar they are. Like it almost is modeled after it. And the second point I'd make is that I think the trend, and you know, MedPAC put out a whole point this year that Medicare Advantage does not save, you know, that much money for the system, even if the insurers are making money off it. I think the trend you will see is that CMS and the government will push that point so that whether you choose a full MA plan or DCE, it has to save the government money, and it'll be a race to that. And this is really for, I think, the insurers out there, that if you are going to take 10, 15% admin, then you have to offer the value that brings over and above what a DCE could do, right? So that's the parity that we're going to get to, so that either one saves the government money. And it's a challenge for kind of where MA is going, I think, in the future.
But those plans in Florida, me being one for the last 35 years, you have to make your money after 15% contractually, and then all the add backs are probably another 5 to 7% of mandatory services you must use with questionable value. And so you have that 65% of the premium to provide all the care and produce a bottom line. I think that went unnoticed, and I think the government sees it very clearly now and says, okay, DCE or risk-bearing entity, you have, you know, 20% more in premium to work with. Don't put it in your pocket, share it with the provider. And I believe that that is going to be a struggle when they try to bring the two programs into parity. I think that we're used to it. That's all we've survived on small premium. So we feel like we've won the lottery, and we are sharing it with our providers, and it's being well received. And I think that's intentional.
And so along those lines, I mean, is the direct contracting model, is that the future, or, you know, maybe will live alongside, you know, assuming that they can demonstrate the success of the model, will live alongside a lot of these more targeted programs like bundled payment, you know, initiatives and other programs as well?
I think they have a role inside the DCE. I think passing the risk on to one entity to sort of quarterback how the funds are dispersed. Certainly, we do share as Richard said earlier, the PCP is the #1, but what we're finding in contracting, and again, maybe a third point the pandemic helped us with, is that getting the attention of hospitals, which normally only like to count the number of people in beds, to get their attention that if you work collaboratively to produce a better outcome, safe discharges and whatever, not only can you improve your metrics, but your cost per day will improve. And if you work with the DCE and you share around these metrics, some of the savings that you're creating, now they're your partner. And whether or not somebody's in the bed or not, you're making money. And now for the first time in my career, I've had several hospital systems, one of the largest being the largest one in the country, ears are wide open listening to, hey, how do we get into value-based payment without having to be at risk ourselves? How can we help you? How can we participate? That's a game changer, you know. And then if you want to factor in the things like bundled payment and so forth, those are all conversations on the table.
And I think as part of these conversations, you know, I certainly don't want to kind of leave post-acute care out of the conversation as well. You know, I think there's been a lot of, you know, attempts to really collaborate between, you know, whether it's, you know, kind of bringing in everyone from primary care to specialists to hospitals to, you know, the post-acute as well. I mean, what are we seeing there in terms of efforts within, even some of these Medicare models and maybe even outside of that to really kind of tie in with what's happening, in the post-acute care setting.
As a provider, I will say, if you don't have a good workflow and system and a village around post-acute care, you're going to sink. So you have to have the high level of engagement before the patient discharge all the way through their next destination and for a period of time. And you have to have a very aggressive engagement in the primary care doctor. And just, in the fee-for-service world, it's a challenge to even know where your patients are at. So getting all of those systems, the technology, the right platforms to all talk to one another and to coordinate the best practice of post-acute care, the services in the home, who are the right providers, what's the right frequency, etc. If you're not well versed in that and have a good process, I wouldn't encourage you to take two-sided risk. I think it's on the top 5 things that you must do well. And there are lots of great partners out there nowadays. I can tell you in the early 90s, it was like finding the needle in the haystack. There's a lot of high level, sophisticated resources and people willing to step up and grow with a risk bearing entity and help them with that process.
And along those lines, I think, Laura and Richard, I'd love to get your perspectives again from both the payer and provider. But obviously payers and providers, we see an effort from both sides in terms of engaging in financial risk arrangements, value-based care payments, value-based payments. But I imagine that there might be different perspectives and different goals. So I'd love to kind of hear your thoughts in terms of maybe how providers are viewing these and what their goals are, and then payers as well, specifically for these kind of financial risk arrangements.
On the provider side, I'll speak to that. Again, in high school, there are more unpopular kids than there are popular kids. It always is, right? There's always that other, and that was part of that unpopular group. That's why I went into medicine, a doctor today, right? No dates and no sports. I'll show them, right? So all to say, there's more, again, what everyone here is saying, you have to meet the providers where they're at. And where they're at is Windows 95, to use as sort of an extreme example. I think we have to recognize it. And they don't know it's Windows 95. They don't even realize. And so the state of education and know-how, you don't know what you don't know. And it's really, you're gonna need those partners to do all these efficient things. You're gonna have a consolidation, and only the strong and efficient and those with know-how will do. Everyone knows what needs to be done. We'll go and do it. And that's the challenge. So I don't think they understand. Everyone is desirous of taking risks. They're all, I believe, a little overconfident. And I think it's almost lambs to a slaughter. It feels that way. When you're taking a risk and trying to improve quality scores and CRG and RAF scores and everything else, you don't even know what your patient panel is. Your patient panel is like 40% off both ways, on and off. I mean, it's your work. There's such a challenge on the fundamentals. And I really do think we're spending too much time on trying to raise the ceiling and not on the floor. All about, one, David Shee, my chief medical officer at City MD and so forth, has always taught me something that now I understand the wisdom of. Quality rich is all about variance control, taking care of the left side of the tail. And everyone tries to work on the right side, the sexy right side of the tail. But for example, diabetes, there's such a variation of physician behavior, such a wide variation, that just by knocking out the left 5% of a tail raises the bar. Everyone tries to move the entire curve to the right. Keep the curve where it is, just work on the left tail. I think we need to, payers, providers, all need to spend time working on that. And that's a policy. I don't think it's within us doctors to do that. Doctors, we love to be creatures of partnerships. I mean, we all want to be a little special, all a little different. We completely resist standardization and repeatability. And I think therefore it's a policy person. One last thing, you talk about right incentives and the structure and the data. Well, when Frank Allen Smith is called Frank Allen Smith with Medicare, and in the Medicaid of the same pair is called Allen Smith, and every office calls a different thing, and we have no standardization of data. You could be on the same EMR, but complete different instances. So I really do think we have a workflow standardization challenge that can't be overcome unless it comes from a payer or a policy.
I would just add on, I think that's where the partnership comes into play. And I think Richard alluded to it. It's like going in there and helping the provider out, even if it's giving some resources to them. You know, in my prior life, when we worked for an IDN, we would have our pharmacist at discharge, making sure that they went through the medications at discharge, making sure that they had their prescriptions filled, or they didn't leave the hospital without their prescriptions. We, you know, put together our own family pharmacy, or if the office needed help prepping charts to make sure they addressed all the quality care gaps or risk adjustment gaps, we would put our own health plan resources in there. So I think it's just, you know, not putting up the barriers of payer versus provider, is being that true partnership. And at the end of the day, we'll all win, the provider and the payer. You know, and, you know, Richard also was just like the data, right? They lack a lot of the data. Sometimes they don't even know if their patient was in a hospital, but the health plan knows. So just that constant feedback loop of data sharing and sharing of resources will benefit everybody in the long run.
I think one other thing Richard made me think of as he talked about popular and unpopular kids is that one thing I would call out all health plans on this is give more providers a chance. I think there's sometimes this thing where they're saying only the biggest will we give that chance to. Give them this chance. And in many ways, maybe, you know, the concern is, well, we have given providers in the past these chance and they didn't do well at it. And we ended up not being able to go claim the dollars on the downside risk against that. Fine. But I think there's a lot of appetite today in capital markets, right? How much private equity and public equity is poured into this sector. What I would do is give more of these providers a chance. They may fail, it's okay, but then go and claim those dollars away from the private equity holders who backed it, but give them that shot instead of saying, I don't know if I want to give you that shot, right? I think there is, especially in the New York market, which I guess is this organization's focus, a pretty high barrier to wanting to give that to the provider organizations. But there's so many that are hiring in really talented people, and bringing in people like Deborah, Richard, and Richard's bringing in people, and they're well capitalized. Give them that shot.
And we actually had a specific question from the audience about what will it take for the New York City metro area health systems to embrace moving forward with value-based compensation. I mean, I guess maybe Michael, on the lines of what you were suggesting, is that, do you see it somewhat as maybe needing the payers to give them more of a shot, maybe even from the payer perspective, maybe they're looking for some further development in terms of experience with risk? You know, do we see this kind of going both ways?
Yeah, and I think that the two things I would do is, one, payers should still do a little bit of diligence on whether or not that provider group is really prepared for it, right? A lot of the things that Deborah and Richard said, they've been through it, they are experienced, and that's why they can say these things. So do some diligence, don't just let anyone in, but do that. And then the other piece is, if they also passed a bunch of diligence from a private equity firm, if you think about this, it's the free market to answer this, right? They had to have gone through due diligence that this really does make sense before they're willing to put capital into a company for this. So therefore, you know, if they lose that money, that's all you got to hold their feet to the fire on and accountability on. That's kind of my point on giving. There's so much capital backing these now that that is a very big possibility, and not all of them will succeed, like I said, but that's where you can actually really meet a lot of them in providing that opportunity.
And Debbie, I think, you know, getting to kind of this issue of experience, which I think we promised our audience very early on with one of these questions we received to get to, you know, as you're rolling out direct contracting models or any value-based payment arrangement, I mean, what are the major pitfalls that we see providers really facing, and that they should think of it as they move forward?
Well, you have to have some experience in value-based care and confidence that you have the correct team. And truthfully, it's very difficult. The pool of people who have really been what I would consider global risk, fully delegated, call them what you want, MSOs, whatever, really isn't that big of a pool. And so I would find experienced people to help and guide me. You need good systems and tools to be able to do that. Now, the pitfalls in launching this in a market, because there are many markets, most markets aren't saturated with MA population for the most part. There are key states that are very busy and big and saturated, and with percentages of 50-60% range, but a lot of markets don't. And a lot of doctors have enjoyed that fee-for-service mentality and payment, and many employee doctors are paid the same way on episodic care. And so changing, that is a headwind. The culture change into embrace risk, and the shift in how you treat patients is significant and can't be underscored. It can be done. It takes some hand holding. It takes a lot of transparency. A lot of people have been burned in the past. So definitely past experiences, especially the folks that have been around since the late 80s and 90s, have had bad experiences with risk. The word capitation is not necessarily embraced right off the bat. Explaining the value of capitation and what that allows a practice to do at first blush is very much of a headwind. But if you persevere and you are completely transparent and you show the physician what he has to gain, and you show the systems, the tools, and the resources you're going to bring to him to be successful, because to Richard's point, many offices that you're going to contract with to adequately have a network to cover a market, they're all over the place. And if you don't have a plan for that, then it's very, very difficult. And then I would say that a lot of risk-based contracting, big plans don't want to go where it's difficult to manage risk. So the inequities that exist throughout communities exist. And then when you go to a market trying to bring these systems and this value to the population, you have to start at ground zero. They don't understand value-based, they don't understand capitation, they don't understand a lot of things, and they have a lack of resources. All of those things can be overcome, but it takes time, talent, energy, resources. I, for one, am very happy with the money that Michael has mentioned several times. It's in healthcare right now, because it's allowing companies that have experience, that want to go out and bring value-based care to all communities, the ability to do that. And so I would say those are some of the strongest headwinds. Then also where there's monopolies in certain markets, you can get locked out. You won't be able to contract appropriately. And I would say the patients get stuck into a system churn where you can't ever get that patient back in a PCMH model with a physician or a PCP as the quarterback. There are a lot of barriers depending on the market. And from major metropolitan areas to a rural area, they're unique. But fundamentally, is getting the buy-in from the PCP to understand value-based and capitation.
Got it. And Richard, did I see that you had something you wanted to add to?
And we all have our when you're a hammer, everything's a nail. So I'm a provider, so I'll speak from the provider leadership aspect. And others, it's really great to hear the high level, sort of the world behind the curtain. But one of the challenges that I think we physicians have to take responsibility for is we don't have enough physician leadership. Okay, doctors are creatures of delayed gratification in everything except for healthcare payers. For some reason, when it comes to this, we will not accept delayed gratification. We have very little trust of this pot of gold if we do all this 18 months from now or 16 months from now. And to get that, you need, I think, leadership. And they don't have to be physicians. But by and large, the groups I've seen done that do it well have a servant leader physician. Many doctor leaders they come in two flavors, like overly idealistic or overly mercenary, right? And they're like, they're just these binary sort of creatures. But to get physician leadership that is able to suspend disbelief and get the buy-in of the providers. It doesn't have to, I've seen non-physicians do it, but it's a little harder. We need leadership that's mission-minded to dream. And I think, what can payers do? I saw a question, what can payers do? Listen, I think if you see one of these guys, you have to invest in them. You have to raise them up. You gotta support them. They're very few, but when you find them, you have to support them so that every time, and they know how to do it, they know how to scale, they know how to do, and they have the trust of the people, of their doctors. Oftentimes, when we're investors, we invest in practices now. It might be 80 doctors, 100 doctors. Only 3 of them actually read the documents. It's the 3 leaders that everyone, he signed it? Okay, I'll sign it. They're not going to read an 80-page document. There's physician leaders, for whatever reason, have the trust of those around them. You need the Pied Pipers. You need these physician whisperers, in addition to all the what needs to be done. Assuming you have computers, assuming you have dashboards, all of this, how do you actually translate that data into workflow, but also what Mike Meng and Stella does so well, and amazingly, is into behavioral economics. Okay, what Mike does, you guys gamified in a brilliant way, not just physician, but everyone's behavior. You need that, and you need different ways of getting people to buy in. And the challenges we find is changing culture, change management. It can't go so fast. How do you find leadership that can keep doctors unhappy at an acceptable pace and can soak up damage, be yelled at all the time, and yet get up every morning and still serve?
Great, and I know we're coming to near the end of our time today, but so I think maybe as kind of maybe some closing words or thoughts, if any of you have really some final thoughts on kind of the future of value-based care, and really where we're heading from here, and what major obstacles we might need to overcome to really kind of achieve that more broadly. Maybe Laura, I'll throw that to you from maybe the payer perspective.
Sure. So yeah, in order for value-based contracting to work and to be successful in the future, I mean, I truly, I've said it numerous times, it's the partnership between the provider and the payer. It's been said, like meeting the provider where they need to be met, being flexible enough to incorporate whatever the wants or the needs are into their workflow and try to provide the resources as needed to the provider's offices, whether it's tools, people, whatever the case may be, because they're your funnel, right? If they're successful, the payer will be successful. So, I think it's transparency, it's partnership, sharing your resources, and making sure both parties are successful, along with the outcome of the member's health is optimized.
Great. And Michael, maybe some closing thoughts?
I think my final words are, first, just a big thank you to this panel here. And maybe that in itself is the most encouraging thing. As we were pulling this panel together, right, it was so easy to get Laura and Deborah and Richard to want to do this. I think it's probably been easier than it's ever been before to get payers, providers to do this. And maybe that in itself is emblematic of where the value-based care is headed in our country, which I'm encouraged by.
Definitely. And so I think, with that, I know we're at the end of our time. I just really want to thank everyone in the audience for joining us today and as part of this conversation. And, I hope everyone has a good rest of their day. So thank you again. And thank you to all the panelists as well. So thank you.
Thank you.
Thank you. Thank you.